Coleman for asking me to give a talk on 3D printing. Definitely something I've become very passionate about, and like to share you some of my experience, particularly relating to osseous deficits. Please feel free to ask any and all the questions you like. At the end, I'll have my email address and some other information if you prefer that method. So just a brief outline. I'm going to talk about 3D printing technology and basic overview of the process and overall indications and examples. And then we'll specifically talk about osseous deficits and in some case examples and finish up with some questions. So there's obviously a potential shift approaching for us in manufacturing plates, screws, and any medical device for that matter. And the reason is moving away from traditional manufacturing is the ability to customize and make complex geometry, as well as it's actually uses less materials and energy, and you can use a variety of materials. But here are some examples from Restore 3D, who is a startup out of Durham. This has been associated with Duke, and they have done some extensive cases, as you see, as some ortho revisions, but also some airway devices. But I mean, a simple Google search will show many other different medical indications for 3D printing. For us, though, for foot and ankle surgery, I like to divvy it up into three different kind of areas where I commonly use 3D printing. Preoperative planning, if you've ever done a 3D printing case, you realize that the case goes much more smoothly than you anticipate because of the extensive preoperative planning, but also the ability to see in 3 dimensions. Cannot be understated. But also instrumentation and guides, whether they're for total ankles or for a lapidus like this, in the middle picture, to basically increase reproducibility, save time. Those guides are actually pretty cheap to print, and you'll make it up on the back end with saving time, but also doing a better, more reproducible surgery. And then finally, implants, which is what we'll focus on here. So in my experience over the last nearly 3 years, in 50 plus cases utilizing 3D printing with custom implants, the first main indication is complex deformity, whether it be Charcot, like these first two examples, where there's significant deformity, bone quality is obviously not great, or even post-traumatic deformity when you get this depressed cuboid fracture nutcracker after a Liz Frank that was treated many years ago, primarily with an X-Fix. Obviously, she continued to lose lateral column length and brought that back out with 3D printed cuboid replacement and then doing our midfoot fusion as we traditionally would. But also, and I'm not going to get into this slide too much because this is the meat of our talk, is with osseous deficits, particularly that involving avascular necrosis, whether it's of a second metatarsal head or of a navicular, or even a AVN of a first met head after a chevron. And then in general, just revision cases, particularly in my experience, navicular fracture non-union, that we used a 3D printed navicular cage, revision large OCDs, which are on the talar shoulder, not amenable to an Oates, and doing like a hemi-talus replacement. And then even doing custom like tibial components for a significant amount of bone loss from post-traumatic issue involving an open pilon several years ago. The common question I get probably most commonly is, what can you expect? You know, when say you've identified a patient, whether they have AVN or this is a complex revision, and you're considering using 3D printing, what is it that you need to, what steps do you need to go through? The first thing is getting a CT scan. MRI can be valuable in addition to, but CT scan, especially for implants, is the imaging modality of choice. Once that's obtained, then you send it to the company, the 3D printing company. In my case, I use Restore. I've used other ones in the past, and this process is similar there. Then you'll have an online meeting, a design meeting with the engineers there. And that's where I tend to learn the most about this stuff, because they're looking at our surgeries or our reconstructions in a very different light from an engineering standpoint rather than a foot and ankle surgeon's point of view. So that is extremely valuable, especially when you're first getting started. Once the design is agreed upon and approved by you, then the implant is printed and processed. And in Restore's case, what makes them different is they do all their manufacturing on site. That is good for quality control, because if there's an issue with the implant, it can easily be corrected and reprinted, but also keeps costs down a significant amount. And then finally, your surgery. And a little bit of that goes behind the scenes with the rep as far as getting the PO and approval through your facility, which is another common question that I get, is having trouble getting some of these expensive implants approved. And if that's the case, please reach out to me. There's several different ways that's been successful in my experience. So without further ado, let's get to the interesting stuff in these cases. So this is a 52-year-old female, otherwise healthy, comes in with just this vague global ankle pain. She had failed multiple steroid injections and bracing from some other providers, came to me for, I think, a third or fourth opinion. And really looking at her x-rays at first glance, not particularly remarkable. But so we get an MRI, which MRI is the most sensitive modality to diagnose avascular necrosis. And you'll see this a lot of edema on the T2s, and then decreased signal on the T1s, and multiple cystic and sclerotic changes. So in the earlier stages such as this, MRI is a good modality when you're looking at the x-rays, not much deformity, not really a history of trauma or fracture. So MRI is great for diagnosis, but the CT scan is better for the surgical planning regarding the 3D printing. It also helps me determine, okay, how much bone is really involved here. I mean, this is majority of the talar body and dome that's very sclerotic with some mixed cystic changes. That's kind of the hallmark of avascular necrosis. So this is a good patient for us to do a straight total talus replacement. Again, not much deformity. The other adjacent joints are pretty much intact. They're not very arthritic. There's not a whole lot of collapse of the talus. So this is a pretty straightforward case for us. Probably the take-home point is, sizing. That is really up to you. I typically go the nominal size, and if you can get the contralateral ankle x-ray, that helps the engineers tremendously. But if you can't, it's still possible to be able to do something like this. But typically in the straight total talus cases, I'll do the nominal size, as well as plus and minus 5%. You can go 10%, 15%, whatever you decide is best. You can also add in some other features to it. So a lot of this can be very personalized to you and your patient. So intra-op, I do anterior approach just like you're doing a total ankle. I can share how to do a talectomy from an anterior approach. It's actually quite easy, and now even doing TTCs, when we have to take out the talus, we often consider just going anterior because it's much easier than going lateral. In my hands, at least now, and in this case, going anterior, we don't have to mess around with malleolar osteotomies or anything like that. So we will get the talus out, make sure all the cartilage on the calcaneus and the tibia is good. Sometimes you have to fix a little defect, which is very easy to do. You got a lot of room to move, and then you start your trials. And then once you decide on your correct size based on range of motion of the trial, as well as stability testing, you'll implant, and that's very easy to do. Again, I can probably show you better in person, but you really plantar flex and invert the foot, and typically doing the straight total talus or even a total talus with the total ankle, you don't have much difficulty getting this implant in. This is then when we do our final range of motion and stability assessment to say, hey, do we have any collateral ligament instability, or in this case, a little bit of equinus, in which case we do the gastroc recession or any ligament repairs as we need. The other thing is the postoperative course is actually quite easy. I'll make them non-weight bearing for a week, more or less, to let the incision heal. And if the incision looks good, then we'll let them start at least protected or basically standing in a cast for a couple of weeks until that incision's healed. And then after the incision's healed, then we start the range of motion and full weight bearing in a cam boot. After 6 weeks, we transition them to an ASO ankle brace, and that's about it. It's actually pretty straightforward. Then when you get into a little bit more complex kind of issues, when you have some avascular necrosis and adjacent joint arthritis, as is in the case of this 79-year-old female with rheumatoid, we do kind of the same thing, get the CT scan. Her AVN is not nearly as extensive as the last case, but really involves a posterior facet. Before 3D printing, I would have done, fusion with this, and a lot of bone graft. The problem is she's already losing some height of the talus. And also you worry about that bone quality. If it is avascular, that it's going to take a long time to heal, if ever. So for this particular case, we decided to go with the total talus, but to make the undersurface porous, in Restore's case, it's a gyroid structure that allows a bony ingrowth. And I can share more details on that if you're interested. But this way we can fuse the calcaneus side, but leave the talonavicular and the tibiotalar joints intact. Here's the CAD images or the computer-aided design that are generated prior to your design meeting, and then you start talking about she has a little bit of deformity, so we need to shift the calcaneus a little bit. So we build that into the implant there. And the one thing I didn't mention for the last case, the other nice thing about Restore is that they have a radio-opaque trials, which makes it a lot easier to kind of visualize where the trial is sitting and where your range of motion is getting held up, and how the implant is just positioned. So at this point, prior to the trials, we prep the posterior, middle, and anterior sets of the calcaneus. That way we know exactly what we need. This is the one case where we had difficulty getting the talus in, and I attribute that because this rough undersurface, which is what we want for bone healing, that made it very difficult to get this basically posterior process cleared over the posterior facet. So you can see this transaxial or calcaneal pin that allowed my fellows and me to basically take turns pulling on it and trying to get this implant in. Once it was in and nice and stable, and then add some screw fixation with a 7.0 and I believe a 5.0 or something of that size or so. And you can use whatever off-the-shelf implant you want. You just got to let the engineers know prior to making the implant so that they design the screw holes appropriately. So from a bone perspective, she's done very well. You can see on the 3-month CT scan, which we always get on these for fusion and for bony ingrowth. One, because we're interested, but also, for future research kind of stuff. But the one complication she had, again, she's elderly, RA with disease-modifying medications. She ended up having a full thickness dehiscence, which is why I'm glad I'm partnered with Coleman, because of his expertise with doing flaps and the microsurgical stuff. So he was able to get closure, and now she's at least 6 or 9 months out, doing very well. So not to change the topic too much, but continuing on with Talus, you can see on these preoperative x-rays, a 62-year-old male, otherwise healthy and very active, still works full-time job, had a fracture, in the remote history, but looks like the fibula is out to length and proper rotation. Has some anterior subluxation, but not a whole lot of other deformity. We get the CT scan to test bone quality, which we always do for our total ankles, especially now because we have a good solution. This would be a case that I would have been very, very apprehensive on throwing a total ankle in because of the amount of sclerotic changes it has in the dome, as well as this large, nearly full thickness a defect in the across the entire talar body. So I probably would have fused this, if it had not been for the 3D printing, or what I would have done 3 years ago or more. The other thing I always preach to my fellows is whenever you see anterior subluxation with end-stage ankle arthritis, you have to think lateral ankle instability and equinus. So preparing for that, the talus is polished and smooth on the articular aspects, but we left this kind of footprint where the ATFL attaches with some eyelets to sew the ATFL back if we need to. That's a non-articular portion, so even if we don't use it, it's not a big deal. And we'll probably allow some soft tissue ingrowth there to add to stability. Because of the amount of arthritis in the tibia, we, rather than go straight total talus, we decided to pair this up with an off-the-shelf tibial component. Again, that's dealer's choice, really whatever tibial component you normally use. The important thing on this case and why I made sure I included it is when you're doing total talus with a total ankle or just the tibial component in poly, is what's your order of operations. I will say, if you're using an off-the-shelf jig, like most companies have, all except one, I guess, I think it is easiest to take the talus out. Then you have plenty of room to do your tibial cuts, and it's actually the easiest tibial cut you'll do. However, if you're using a 3D printed guide for the tibial resection, keep the talus intact. That way you can ensure that the guide sits properly, because that guide is based on where all the osteophytes and imperfections in the ankle are sitting. So again, not to beat a dead horse or anything, but if you're using a custom cutting guide for the tibial component, do your tibial cut first, then take out the talus and the tibial resection. If you're using off the shelf, you can do whatever, however you want, but I would suggest you take the talus out completely, then do your tibial cut. So that's just kind of the one pearl on this case. And then, so because we use the 3D printed custom cutting guide, you can see us doing our tibial cut, then we take out the talus and take out our tibial resection, and then it's sizing the tibia and then sizing our talus and poly. Of course, testing range of motion and stability and closing this up. Once we got the talus back out to length, he did need a gastroc recession, but he did not need a formal lateral ankle stabilization. So we ended up not needing that one design feature, but it was nice to have. And as far as post-op goes, very similar to the total talus case, in that we splint non-weight bearing for a week, then we allow them to stand in a cast but no walking for 2, and then weight bearing is tolerated in cam boot with passive range of motion at 3 weeks to 6 weeks, and then transitioning to an ASO as long as that incision heals up just fine. If they need physical therapy, I wait until 10-12 weeks just to make sure we have osseous stability. So here he is at nearly 6 months. He's coming up on a year now, doing fantastic. He's probably one of the best outcomes that we've had with any of these cases. Here's another example of end-stage post-traumatic ankle arthritis and subtalar joint arthritis. This lady was seeing me hoping to receive a total ankle. We get her CT scan, and looking at the amount of osteopenia in her distal tibia is very concerning, even if we do replace the talus. So I wasn't completely confident. But, you know, the other thing is she had a prior open fracture. And so now I worry about latent infection and all that stuff. So what we decided to do is, because the talus was very avascular, would have been difficult to fuse anyway, is let's take the talus out. And as we were doing so, of course, we broke the malleolus because our bone quality was so poor. So we put the antibiotic spacer in, decide we're going to convert this to a fusion. So we're waiting on cultures. But in the meantime, the nice thing, again, about Restore 3D is that they do all their printing on site. So literally the patient was still on the table, and I called the company and said, hey, we're going to have to stage this. I need a sphere or a talar cage with TTC fusion kind of thing. And said, we send them the CT scans, both pre and post-op, after that first stage. And the patient didn't even end up having to go home. We were able to get this talar cage within a week. And so we just kept her in the hospital, kept her non-weight bearing and safe, and then threw in the nail with the talar cage. We always graph these. Her cultures were negative, by the way, so we were able to do this quickly. But we basically collect all the reamings, and then we use a device to separate the blood and marrow from the solid bone graft, and use the solid bone graft to pack into the pores of the implant, and then close her up. And this is a little bit, this is not a diabetic Charcot kind of thing. She's fully sensate. So with these people, I keep them non-weight bearing completely for 3 weeks, and I let them stand in a cast from 3 to 6 weeks, and then progressive weight bearing from there. She's also done fantastic. Obviously a little disappointed that she didn't get her total ankle, but she didn't have much range of motion anyway before surgery, so it wasn't that much of a change for her. Now she doesn't have the pain that she did before. Shifting gears a little bit. What's that?
Was that the lady who her husband carried her?
Yes.
Okay.
Yeah, she was very small, and he was big and burly, so he would just carry her to her the appointments and up and down stairs. Yeah.
All right.
It's funny the things you remember, I guess. Some of these.
Okay.
All right. Well, and here's a really common indication, and I don't want to say that I would never do this, but I just see so many of them fail fairly quickly. This lady, healthy, great patient, had bilateral celastic implants for hallux limitus or rigidus about 3 years ago. Comes to me with complaints of sub-first med head pain, kind of sesamoiditis, but really from the hallux being elevated and cocked up, but also not having any active plantar flexion. So she's in a bad position. She's got now a large deficit. Now what do you do? Before 3D printing, big bone block arthrodesis or an in situ fusion would have probably been at the top of my list. However, there's issues with both of those, particularly with the bone graft. Above 2 centimeters or so, you're really kind of praying for any kind of bony ingrowth or ongrowth onto that bone graft. And you're limited by creeping substitution. I've not seen that with the cages. It seems as though that doesn't follow the same sort of limitation at 2 centimeters. It seems like you can use larger metallic spacers than you can allograft. So, but that's an area of potential future research. So preoperative planning, you see not only where this implant is sticking out plantarly, but large deficit. This pale white color is where her toe is clinically, and this is where we need it to be. So that helps the engineers kind of formulate the size and shape of the implant. Now, I've done several of these, many of them different ways. This is my go-to kind of design for this implant of having 2 convex surfaces. It just seems to be a more stable construct, and allows you all the degrees of freedom, and then two, keeping the diameter of this implant slightly smaller than the cortical diameter of the adjacent bone to allow bone to grow over top of the implant is ideal, and this design allows you to do so. So then once we get that implant out, then we're prepping both of the surfaces, very similar to what you would do with a normal first MPJ fusion, except you're using only one side of the reamer. So you're using the male size reamer on both the met head and the proximal phalanx to accommodate that implant. Once you get this in, we've done it also where we have screws going from the implant into the phalanx and the metatarsal. Believe it or not, once you get things out to length, and that rough surface makes things intrinsically fairly stable. I would still say, add some additional fixation. Like in her case, we threw a 3-5 plate over top, getting at least 3 to 4 screws in each side bicortically. She has done, again, very, very well. And I can, in the future on another conversation, talk about some of the failures that I've had with particularly this type of thing. We actually just recently did her contralateral side, and again, is done well so far. She's probably only 4 to 6 weeks out from her other side. This is now the last case, probably one of the more interesting ones. This osseous deficit, I guess, again, is AVN. This lady, very healthy 50-year-old. She's actually a physical therapist. She has had a chronic stress fracture that has just become more painful and bothersome, limiting her activities. Unfortunately, with kind of the soft tissue attachments, particularly the PT tendon, replacing the navicular isn't, an option quite yet, maybe in the future. So she needs some sort of fusion, particularly medial column. The problem, if you've done any of the medial columns with a big bone block, again, just like the last case, I just have a lot of trouble getting those fused and obtaining stable fixation. So with her, again, we get the pre-op CT to generate our CAD or computer-aided design, and we have fixed these in many different ways, both plate. This one we decided to use a mini nail to see if we could spare the first TMT to allow some range of motion so we don't lock everything up. But this was kind of, again, dealer's choice. I would say, I favor either using the mini nails or a large medial column plate. It seems as though obtaining stable fixation, even with these type of cages, is rather challenging. So we're still kind of learning on some of these. We've had a lot of issues with broken hardware and having to revise that broken hardware. Fortunately, we haven't had to majorly revise anyone yet, but still taking somebody back to for another surgery that's unplanned isn't ideal. So we get this, we decided to do like combined medial and lateral approach, much like you would do like talar neck kind of stuff to get the navicular out. Then we're using the sizer. And just like the first MPJ, which I think I failed to mention, is, sizing how far or what's the length of the implant you want. What I kind of rely on is the physiologic tension of the soft tissue surrounding whatever you are replacing. So if you're not engaging those tendons and ligaments, you're not going to have as stable as an implant, but the bone has less distance to move. But you also don't want to shorten the medial column up tremendously. So that's what I have used as a rule of thumb. It seems to work out okay so far. But again, we're still kind of learning on these. So the other nice thing was, which makes this case different compared to my other navicular cases, is we had a 3D printed custom jig that not only served as a trial, but also to help us throw our guide pin, given we have a very small corridor to throw across the the medial cuneiform and into the talus. So that guide is pinned in place, and then this guide wire is placed. And we ream over top of this wire, leaving this implant in. Then we take everything out, place the navicular cage and the rod after. Of course, grafting the implant. Maybe it's how I was trained, but anytime I'm doing medial column fusions, I'm also doing subtalar joint just to provide some additional stability of the hind foot. So this case went fantastic intraoperatively, as well as even at 3 months, which is where she's at now. Unfortunately, she broke the distal end of the rod where the crosslock screw came in, so we had to remove that, and we plated over top. But otherwise, she's doing well. Again, it seems to be these navicular cases of obtaining stable fixation and keeping them non-weight bearing for an extended period of time is what I would recommend. So with that being said, again, I thank you for all the time. I tried to roll through those very quickly. Coleman gave me a 30-minute time limit, and I think I finished 5 minutes or so over. But that way we had plenty of time for questions, and we can revisit those cases. So again, here's my email address. Feel free to reach out. Sarah James is the head of clinical solutions at Restored. So if you have potential cases, you want to bounce ideas off of me or her, feel free to contact either one of us. So with that being said, I think we have a couple questions.
Yeah, I'll start off by asking one of the questions that was in the chat room, and then just personally, I want you to address kind of the first part is a timeline for production, and when, essentially when the patient comes in and you decide to do this, okay to schedule a case for the audience to give them a timeline.
Yeah.
And then also when I know that we've had this discussion, but I think it's worth talking about putting plates within or built into the implants versus outside or separate
Yes.
to the implant.
Yeah, and I can show some case examples if anybody's interested on that second point. But the first question of, so from the time you identify a patient, you obtain the CT scan and it's mailed to the company. For a total talus, because these are cobalt chrome and then hand polished for an extended period of time, they take a little bit longer, and they're typically ready to go at 3 to 4 weeks once they receive the CT scan. Now, some like the tibial cages or the first MPJ cages, they can do much quicker because they're titanium, and just the manufacturing process is much quicker. So we've done those. Well, I gave the one example. The quickest I had one turnaround was less than a week, but typically I'm about 4 weeks scheduled out, so it tends not to be a major issue, at least in my practice. But I think the probably more common issue people have is getting them approved at their facility. And so kind of knowing the literature and knowing, potential examples of failures of, or the limitations of the way we traditionally fix some of these osseous deficits to present to your administration has worked for me, at least in the past. Then the second question was regarding, like particularly for the first MPJ. I'll be very honest, I didn't include these first couple of first MPJs that I did with a different company, that the cage was designed to have the plate connected to it, which is a bad idea. First and foremost, because it doesn't give you as many ways to position the implant and the toe. You're kind of locked in, you're determined already by that plate that's fixed to the cage. But also if, patient ends up having painful hardware and you got to take the plate out, well, you got to take the cage out too then. So without reservation, I would highly recommend to anybody doing them in two separate kind of components of having the 3D printed cage and then an off-the-shelf first MPJ. Typically, the revision plates work better because they're a little bit longer. So we use off-the-shelf, fixation for that.
The next question is about essentially when would you never do this, or what kind of contraindications do you see, with patients, or whether it's compliance or physiological?
Yes, and again, that's a great question that I didn't really harp on too much that I probably should have. First, especially getting started with doing this stuff, I would say on average, people have at least one, if not double the amount of preoperative appointments that I normally would have. First, to make sure that they know that they're getting something, let's be honest, experimental. Of course, I tell them the potential advantages and disadvantages of doing something like even this case with the first MPJ, and realizing that they're also getting a custom implant. So if they cancel the case, then we can't use this implant on anyone else but them. So that is probably my biggest concern, is that they cancel the case. Now, obviously, if you have somebody that's very anxious, high strung, is not gonna, bode well for potential revision in case there's a problem or the uncertainty. Of course, I have had to turn people away that were just struck me as very unreasonable and treated them in a more traditional way. So as far as like total ankle kind of goes, AVN and poor bone quality used to be my probably most common reason for me not to do a total ankle, other than diabetic neuropathy. So now with being able to do a total talus, that kind of goes out the window, that contraindication of poor bone quality, because you can replace whatever is poor for the most part, I guess. And even like the one case Coleman, you and I did together, a couple of years ago, of doing a custom tibial component kind of thing. So basically, AVN doesn't scare me nearly as much, but if they have neuropathy, then I'm definitely not replacing, whether it's a total talus or a total ankle, because you just know that that's not going to hold up. But obviously for fusion type things like Charcot, especially when you get these pretty wicked deformities or like neglected fractures, which now they've developed deformity on, and they're getting fused, that's obviously a big indication or common indication for us in that regard.
A lot of people are kind of privately messaging me also, but a kind of a generic question of, how do you convince your hospital to cover the cost of it? I don't talk about like how much they cost, but like as far as, yeah.
So I'll tell you the story. My first case that I did, it's been a little over 2.5 years ago. It was a total talus case, and it was a young girl, super healthy, had a talar neck fracture, ended up with AVN, and basically was offered amputation by some of the other area ortho guys, which she obviously did not want, and they, kind of convinced her that if she was to have a fusion, then she would end up with a lot of problems. And so she was the perfect first case for me. But I was very apprehensive on going to my administration and asking for, an experimental way of fixing something, especially because we're not at a research institution, but also the cost of it. But what I did for that patient is print off, what it costs for an amputation, or the problems with fusing someone in their 30s who is very active, the issues with that, and saying, we have the potential to change someone's life here, that, let's be honest, if she has a successful outcome, she's going to be our biggest advocate. Fortunately, I think Coleman could attest to this. We are very spoiled with our administration and their openness and hearing us out. Of course, they say no every once in a while, but at least we get FaceTime with them. Obviously, at larger institutions, you don't sometimes have all that. But I think, for like TTC, like for this case in the bottom left-hand corner, sharing the literature or even your failures that you've done a femoral head or a straight tibiocalcaneal fusion in the problems that creates one, leg length discrepancy or non-unions for the femoral heads. The femoral heads also are not very cheap. And these can be printed up relatively quickly, from my understanding, fairly comparable to a femoral head. So there's not a whole lot of price discrepancy. The other thing is you talk about, well, if I had to use an X-Fix to do callus distraction, I can tell you right now that the X-Fix is going to be more expensive than these. So that's another potential thing to bring up. So
yeah.
Obviously, if you're blessed like we are and having a smaller facility that we can pop into our administration and let them hear us out and hear their concerns or what, that's been successful for me at least. And then once they start seeing a couple of successful cases and the marketing that generates and the amount of additional cases that people are coming, because let's face it, when you're able to do some of this advanced stuff, you're going to see more EPFs and plantar fasciitis, the very simple things that make a lot of money for the hospital. So so it ends up making up in the long run, in my opinion, at least from my perspective. But I completely understand that not everybody has it as good as we do.
Someone, where'd it go? Oh, what do typical 1, 3, or even 10-year outcomes look like for patients who undergo talar implants? I'm assuming exclusive.
No one knows. I mean, I think the first one was put in maybe 3 or 3.5 years ago.
Yeah, that's what I thought.
And that's where all this experimental stuff kind of comes in. Salem Perec, has probably done the most total talus implants in the country. And he has the one publication that I'm aware of regarding the 3D printed total talus. The last time that I spoke with him, as well as some of my other colleagues, I have not heard of anyone needing one revised, in that short time span. So I know that doesn't really answer the question, but only time will tell. Obviously, with the total talus, like straight total talus case, like the one I showed, she doesn't have arthritis on her tibia or of her calcaneal facets, but we know that this cobalt chrome implant is not like normal cartilage or normal bone, so that it's going to erode away. Knock on wood, my first one that I did, again, more than 2.5 years ago, nearly 3 years, she hasn't needed it revised. So that's all I can say about that. I always prepare these type of people that this is not going to be your last ankle surgery, but with the 3D printing, it doesn't burn any bridges. In my mind, if you fuse this and do TTC with even the cage or what, to do a takedown, an arthrodesis takedown and convert it to an ankle replacement, in my experience, does not work as well as what one may think. So for the right patient that understands that they're going to undergo another surgery in their lifetime, just don't know when, if they can accept that. But to that point, there's several patients that said, nope, I want one procedure, and I don't want to mess around with this any longer. So fusions is their option.
Yeah. Dr. Rodriguez has his hand up, or his virtual hand up. I don't know if you can unmute yourself.
Hey, Peter. Hi,
Hey,
Gardo. Listen, what a wonderful lecture, first and foremost. Uh, Tell me this, Peter, when you admit the patient, if there's any for custom-made implants, if there's a different type of DRG or something along those lines that the admissions are easier to be absorbed in the hospital?
that's a good question. I I don't believe so because as of right now, there's a couple CPT codes that you can put down on your billing sheet, but they're non-reimbursable right now. As far from the
So the,
facility standpoint,
so the custom implant itself versus just implant, there's not an additional compensation to the hospital due to the fact that it's a high level implant with a higher cost.
correct. To my knowledge, there's not, at least yet.
The benefit for, sorry to interrupt, the benefit for doing the custom is that the hospital gets the reimbursement for the bilateral scans. So, theoretically, they're making up some of it. If you do the CT scan at the hospital for the restored, then, then they make some money off of that. And that's supposed to pick up kind of that extra money that they have to spend on the custom.
I hear you. Okay, thank you.
No, but Dr. Rodriguez, that's a great point. Hopefully that changes. As again, like the last question, as we get a little bit of even midterm outcome kind of data, I don't foresee, insurance companies aren't going to want to pay for anything if they don't have to. So until we have published data that says this is a viable option, I don't foresee that changing anytime soon. So hopefully that changes sooner rather than later, because then even more people can be helped from these cases. And let's be honest, some of the cases I showed, it might be next year that they need some big revision. You just don't know. All you can do is make the best decision you can for the patient and make sure they are making the best informed decision. And that's where additional time and additional pre-op appointments help, as well as bringing in family and kind of showing them. The other nice thing that we're trying to implement is obtaining models. So for people like with a complex Charcot deformity, is having a 3D printed custom model of their foot and being able to show exactly what you're doing. In my mind, would be the next kind of step, or where we would like to go next with this. Then the patient education aspect is so much better.
Thank you so much, Peter. Wonderful lecture once again.
Thank you.
Let's, Pete, if you can go to your last slide and just leave your email up for everybody. And then, obviously, thank you very much for doing this. I always feel like I'm going into Space Mountain whenever I go into your ORs with this stuff.
Yeah, well, and honestly, and my last kind of point is, since Coleman and I started working together, we have a little bit different of passions, but of trying to do the best things that we possibly can for our patients and developing additional skills and everything. So I can't thank you enough for joining me, for taking them out of a metropolitan area to a rural area. I mean, that doesn't happen very often. And then getting the amount of volume of great cases, because now we're pulling things away from the metropolitan areas to a small facility. So, if you're going to do these things, you do it right. You take the extra time that you're not paid for again, but it will pay off. You will feel better about yourself because you're, again, it's not the best choice for everyone, but for many patients, it's valuable to not burn a bridge. So my email address, and if you email me, I'll give you my cell phone, but not knowing if this is getting shared on the internet, and want to put my cell phone on.
Yeah.
But just my name, Peter D. Don't forget my middle initial when I made this email address. I don't know, 20 years ago or something. I didn't think that that would be a big deal, but a lot of people forget my middle initial. So, and if I don't answer, call Coleman and he'll definitely forward it to me. And then again, Sarah, who is an engineer herself. She is a great resource. If she doesn't know the answers to questions, she'll get in contact with someone who does.